our public board meeting. So just to remind you that this is a meeting held in public, so we're being filmed, and I think we're advised in this room that the microphones are very, very sensitive. So be careful what you whisper. Welcome all. We've got two new members of our board to welcome. We're very, very pleased to welcome our associate non-executive directors. We're going to welcome Deepti Alan. You've already made a contribution to what we do, so we're very pleased that you're here. And also you, Dunbar, we're very, very pleased that you're joining us. They're going to be working with us for probably the next 9 months or so. And you'll meet them in all sorts of different settings as this programme goes on to develop. So you're very welcome to join us. I don't think I've got any other special welcomes other than John, who, of all the people in this organisation that could come and choose to observe our board, and it's an open invitation to anyone in a leadership position, only John accepts our responsibility, that invitation. So you're always very welcome, John. I'm going to ask you just before we start if there are any declarations of interest anyone would like to make at this point in the meeting. And I'm now going to attempt to get the apologies right for the meeting. We've got apologies from Andrew Burnell, from Helen Grimwood, and from Jason Stamp, and from Amanda Bloor. Covers our apologies. And Jonathan has to depart the meeting at 12:25.
I'll be back about 2 o'clock.
Jonathan, I'm back about 2 o'clock. I hope you get your lunch somewhere, Jonathan. The first job is to go through the minutes of our previous meeting. So I'm going to do that by turning the page. So let's start on page 2, page 3. Actually, there is a matter arising on here, which I think Nigel will speak of later, which hasn't come up as an action. We said it was also agreed that further analysis of approximately 90% of the Integrated Care Board Freedom to Speak Up contacts are from women of Black, Asian or minority ethnic backgrounds. And we need to understand that. So very pertinent in terms of the conversation we've just had. And I realise it hasn't come up as an action, but that is something that we need to understand. And we said so at the time.
It was on the action plan, but it's being put back.
Yeah.
February. But yeah, I can update.
And it shouldn't take us so long as February to understand that, I don't think. Page 3, 4, 5, 6, 7, 8. And I think that, Stephen, this issue of the delayed release of the service development funding is going to come up later in our private meeting, isn't it?
It is.
And 9, page 9. And on page 9, we've talked about the Oliver McGowan training a number of times. I think that training is being updated, but it is something the board needs to see. And I did ask if we had a date in mind for that. Mike?
Yes, yeah, we're just confirming whether the national training that is designed for boards has been issued yet. As soon as we've got confirmation of that, we will schedule this training.
Okay. This has been on our list for a long time, so it's something that we need to do.
Excuse me, can I come in? So, because there is obviously the first stage of Oliver McGowan training, so everybody can do that online. So if people haven't done that, then I would ask everybody to do that, please.
Okay, so can we make that a proper action then? And we'll double check then in a month's time that we have all done that training online ourselves. So we would need the links and things, Mike, to make sure that we could do that. Okay, thank you. Item 5 are matters arising from previous meetings. The question from the member of public is closed. And then there are 2 issues there, Teresa, that aren't due till next month, relating to the paper we had around suicide. Thank you. I'm not aware of any items of any other business. No. Okay. Let's start then with Do you mind, Karina, if we start with the voice of lived experience first, item 8? I said Karina looking at you, Anya. Do you think, oh, John Cleese joke, isn't it? Do you think we could do voice of lived experience first, please, Anya? Would that be all right?
Of course, thank you, Chair. So you've got a pack in the pack, and this month we wanted to focus on NHS 111. Colleagues may remember that we brought a snapshot of this insight several months ago, but the key focus groups with key audiences were put on hold in the pre-election period. So this is the fuller analysis, and we've just brought the headlines so that you can see them. I will just go through some key points, if that's okay, Chair, but I think there's quite a key point that I just wanted to make at the beginning, and this is about thinking how some of the learnings from this work help us in thinking about perhaps future direction, particularly in terms of where we want to signpost and drive the public to, because I think what this is showing, and as we get into some of the detail, is that we know there are still some learned behaviours, if you like, preferences of where people go, particularly for non-urgent treatment, that we probably want to redirect some of that. Particularly, you'll see in there that the go-to is still to go to your GP. I think we all want to move part of that to other more appropriate services. So I think some of the learnings here apply, whether it's NHS 111, pharmacy first, etc., with the idea of helping us to think about where do we want to direct people to, and then how do we really make sure that people have got the fullest awareness of what that service is and how to use it, and then we optimise the service delivery and the customer journey to make sure that they have that onward confidence and the behaviour therefore changes, if that makes sense. But I will just go through some of the key headlines around this, and again just to state why we did this, which was quite an extensive piece of insight. So the national directive just before winter was to focus on 111, and again trying to relieve some of that winter pressure by signposting members of the public through 111 primarily as a triage point. And you may have recalled the national advertising campaign that ran, that we then also further broadcast across our region. But what we were really keen to understand again is, well, what does this actually mean to the public? Are they understanding what 111 is? Are they using it? What is their experience of 111 if they are? Again, in order to pick up some of that more behavioural insight that we can use to develop both our service and the communication that sits around that service. So you can see that we had around about 1,200 direct engagements in terms of survey responses and face-to-face engagement, particularly with key groups, and we had nearly 14,000 people that responded via social media. What we're finding is social media is a really helpful way of doing some of this insight with the public, particularly in terms of things like snap polls and capturing insight, particularly on service use. But just to whip through some of the key headlines that are on slides 4 and 5. So overall, the vast majority of people across all of the different target audience groups had heard of NHS 111, and mainly by media channels. So there's signalling there that some of that mass media is working in terms of getting the message across. However, only 71% have used the service within the last 2 years. So there's a significant opportunity to increase use. 28% had either never used NHS 111 or had used it more than 2 years ago. And when we delved into a little bit more around that, we can see that there's perhaps a bit of a lack of confidence in actually using NHS 111. So in particular, just over half of the people that had used the service felt satisfied with the service. So there is something there around improving the satisfaction. As I've just touched on, 61%, so most people, not the majority, but most people would go to their GP if they are feeling unwell and for non-urgent care. But for some particular demographic groups, that some of the behaviour is different. So from BAME groups, they were more inclined to go directly to A&E because of some of perhaps what happens in other countries. They were unaware of some of the other options available, and some of the norm in other parts of the world is perhaps to go directly to A&E. Interestingly, and I think this clinical colleagues may want to comment on this, but the vast majority of people using 111 do so via the telephone, so over 96%. Only 13.8 are using online, and a very small number, 4.9, are using the app, and we all know the opportunity that exists via the app. But again, there's a lot of potential there, and particularly if you go into some of the different groups, particularly younger people, which are not unexpected, you know, there's more opportunity there to drive use on digital platforms and via the app. And interestingly, there's very variable awareness of the services that are available via 111. So in particular, the least known services were pharmacy prescriptions, mental health support, and emergency dental appointments. And of course, we again all know that we want to drive more to pharmacy first. We know the issues that we've got with dental. So again, there's lots of things in the detail here where there's the opportunity to better support people to access the right service in the right way, if we were able to, in essence, triage more through the 111 route. And linked to that, there were no particular barriers that were identified, which again presents an opportunity. The main issues, if you like, that make people avoid using 111 are either real or perceived delays in receiving the care or advice by 111. Again, perceived or real levels of expertise. And it goes back to something that we also pick up in some of the primary care insight that we do, that in the main, the public still have a reluctance to speak to the receptionist or the person at the end of the telephone, because they don't feel they're speaking to somebody medically, clinically equipped to help them. And that's a behavioural piece as well that we need to do further work on, and linked to that lack of trust. You can see the detail in terms of the different groups that we spoke to, but just a couple of things to draw out, particularly in relation to the services. So older people had the least knowledge of the variety of services available by 111, but younger people had the most knowledge. And interestingly, when you look at the younger person's response as well, they were also more interested in looking at other options as well, so chatbots, etc., to be able to get their medical advice or health advice, which will be helpful when we're thinking about design for the future and that element of work. You can see that there are some particular challenges that were identified by people with protected characteristics, so particularly the sense that there were often no BSL interpreters available, simple language. There was a sense, particularly from people with a learning disability, that often the language used was quite complicated, and that put them off or left them feeling quite anxious. And there was similar feedback actually from parents with young children, that they were asked too many questions, and in a stressful situation where they've got a poorly child, they were finding it quite overwhelming, and so that was leading them again to go to a different service rather than 111. And again, from some of our members of our BAME communities, they found there were cultural barriers and just a general lack of understanding around NHS. So they had a much lower understanding of NHS. And again, NHS 1111. And again, a common theme that comes out in most of our insight work is around the travel and transport. And again, particularly some groups, so older residents in particular, there was a reluctance to contact 111 for fear that they would be directed to a service outside their immediate geography. And there was a concern around the travel and transport elements to that. So I'll stop there, Chair. Thank you. They're just some of the headlines from this. We obviously have fed all of this back to Yas, who provide our 111 service, and we will be considering all all of this feedback, both directly in relation to our communications activity, but as I say, this is really helpful for that broader piece around designing services for the future. But very happy to take any questions. Thank you.
Thanks, Anya. And are we satisfied that Yorkshire Ambulance Service are taking our this feedback very seriously?
I believe so. Yes, I will follow that up.
Okay, because it would be good to know if they make any changes as a result. Stephen?
Well, I just amplify that point. I know people said before. I mean, it's really interesting information and suggests a number of things, and you fed back where the next step is. But there is something about closing the loop then on that feedback.
Yes.
I mean, so somewhere in our cycle, given that we're taking the time to get these insights and so on, that we say, what then? If I put it very bluntly, well, so what then? What's actually happened as a result? So I just reinforcing your point, actually.
Yeah.
I think it is important that we do that. Thank you.
Any other comments? Anything anyone wants to add? Brent, you look like you were about to say something.
I was just going to pick up on the point about the mental health awareness aspects. When was this done, Anya?
So the general piece was done late spring, early summer, and then the focus group activity across the summer period.
We had a soft launch of the one
Yes.
in the kind of latter part of last calendar year, and then obviously the formal national launch was only after the election.
Yeah.
So I'm not surprised by that to some extent. Obviously, that is the main route now for crisis services. People, so obviously we're starting to get a bit more traction on that. So I think we'd see a bit more input in there, but I think it might be helpful for that. To perhaps come back to the collaborative, so we can have some further conversations around what we're doing locally for our own routes, around websites and various other things to promote that. The other thing was on the learning disability access and thinking again about using the collaboratives, our collaborative, to draw on some of our easy read interpretation resources, and obviously linking in with some of the third sector organisations that we work with on that to land it. And I know it comes through in the recommendations about a comms campaign, looking at, I guess, underserved communities, but I'd quite like to draw that out particularly.
Thanks,
Are
Brent.
you referring to 111 Press 2 for mental health services? Yes, okay, thank you.
But more generally for the learning disability group, the whole thing.
Charlie, then Peter.
Thank you, Anya. Thanks for this. A note of caution about the concept of BAME, because it's a rubbish concept. It covers so many different groups of people that combining them together is probably an insult to most of us. And I see a particular challenge here. Because in principle, BAME might well relate to immigrant communities from the 1950s, 50, 60, 70 years. But a lot of the insight appears to be about very recent immigrants. Now, if we're having Windrush, the Windrush generation and very, very recent immigrants under the same conceptual heading, we're really combining the wrong things. So can we begin to differentiate what BAME is?
Yes. Yeah. And I'm just looking in the detail actually, because I would be able to tell you the different groups that were spoken to. But thank you, Charlie. Very good.
Peter.
A similar related point was just some unease around that catch-all term of cultural barriers or cultural differences, and maybe just resolving that when we have reports, if we think there is a cultural barrier or a cultural difference, we spell out what it is, because I think that's something we've rehearsed. We don't understand necessarily.
Thank you. Nigel.
Yeah, thanks, Anya. It's really good piece of work. I think what it draws out for me is the sort of the multiple lines of communication into the health arena and the confusion that can generate. And one of the things that 111 was set up for about 12 years ago was a single point of contact into the NHS, and I don't think we've really pushed out on that vision. Really, if it is that, then where would we go in the next 5 or 10 years with it? Definitely, the online dispositions when you go through it seem to track better than the verbal ones. So the data shows. So there's something about how we sort of push out more with technology and pushing GP 1111 online. as one of the things that people go to, especially for same day, next day urgent care.
Yeah, thank you, Nigel. Richard.
Yeah, it's fascinating. A really good set of insights. They do make me think it's really hard for the general public to understand where they go to get access to what service. And then it got me further thinking about blueprints and future operating model, because as you know, a typical operating model defines what services are delivered to what groups through what channels. And if this is really about our phone channel and our digital channel, it's really important to nail all that down in our future blueprint. And I guess that just amplifies for me the need to have YAS as a very, very close partner in terms of developing those future models to make sure it's all joined up. Otherwise, it's going to get incredibly confusing for our population.
Yeah, just that, that's really important point, Richard. Just a bit of your reassurance that in the detailed discussion in the wider leaders forum for the system, YAS are a very active participant, and it sort of connects to the debate that you were referring to, I think, Nigel, in some respects. So just to reassure you that's accommodated there. Thank you.
This has me thinking, Anya, about our winter communications. That hierarchy: first pharmacy, second NHS 111, third your GP, fourth. That hierarchy of communication for your health, which everyone in the population should be able to recite, in my view. If we all understood that hierarchy, that would be great. And I think this connects to that. And I think we've talked about that before. We talked about our winter plans, haven't we? Does everybody understand? So, and how do we get to those harder to reach groups? Jonathan.
Yeah, just do we still use local authority newsletters and things to advertise this? So I know we used to a lot, and you would take page in, say, the East Riding newsletter. I didn't know if that was still going on. So I mean, that would be an ideal time to put that sort of winter information in.
Lovely, thank you. Thank you, Anya. It was an interesting presentation. As usual with all of this information, it's so what, isn't it? What do we do next? But I think perhaps we've got some ways forward having listened to that. So thank you. So let's just skedaddle back now to item 7. For those of you who aren't so used to attending board, we always start our board meeting, the formal part of our board meeting, by looking at our board assurance framework. The board assurance framework details the key risks that we think exist in respect of the achievement of our strategy. And it's a dynamic document, so it's a document we use to preface the board meeting, and we also revisit it at the end of the board meeting to check how do we now feel about those risks as a result of the meeting of the board. And I'm always very grateful to Serena, who helps me on this topic. I don't know if there are any areas you particularly want to raise, Karina, today in relation to the BAF.
Thank you, Chair. Just a couple, because I'll take the covering paper as read, but there are a couple of points. Of course, as you say, we build the BAF around our strategic objectives of leading for excellence, prevention, sustainability and voice at the heart. And we've had regular updates on some of our risks in the board assurance framework that are grouped under those headings, namely leading for excellence. There are 3 of the risks there that have all had mitigating actions updated. Particular note, I think, is risk A3, which is the failure to develop data and digital maturity, including the cyber security piece in there. And I think it's just really useful to point out that relates to the funding that has been delayed previously, but has now been released as well, which we're working across the system on how we use that effectively to further advance our cyber security arrangements. And I'm sure it'll come up later today when we have our training on cyber security, but just to make people aware around that. And then I think there is some key updates around the sustainability piece around our delivering our plan for 24-25. Some key actions completed there that people may wish to note. And also later on the agenda for today, linked to the voice at the heart, there's obviously a couple of items that will address some of the mitigating actions in there. At the moment, most of our, well, all of our risks still remain in the same position. There's been no particular movement in terms of status or out of appetite. So where they were last month, they still remain.
Okay. So Stephen has a comment.
Well, I want to
first.
come in because I would have said this under my report, but I'm sufficiently concerned to say it now. And so I'm really talking about A2 and C3, I think. So that's about the in-year performance. So I don't want to get into the detail here because there are further reports. And I want one other thing, Jack, just to test with board colleagues arising from our earlier conversation about equality, diversity and inclusion. So I've got 3 concerns about the operating performance in year, urgent and emergency care, which is obviously a national concern, but whilst we saw improvement during the course of July, we're now seeing quite a significant deterioration in percentage performance terms. I'll register that. I'm also very concerned about the diagnostic service elements of our in-year operating performance, where I think we're significantly adrift what we agreed to. And then I'm particularly concerned about the interaction between where we are with our workforce plan in 24-25 and how that reads across to finances. Now, I know we're going to have some more detailed debate later about that, but I just feel it's important from the chief exec's point of view to register that, because if you simply look at the reports, you won't get a sense of my concern and our collective concern about the mitigating actions I think that will need to arise to address that. So I just want to land that. I think on the discussion earlier, it's really a question, because I think it probably takes us to C6. I think it's Teresa or somewhere. In terms of the comparative performance on EDI, that was alluded to in the earlier conversation, does that make any difference then to our risk in that context? It's just a question to raise, but I think given the power of that discussion earlier and some of the things that we learned, I do wonder whether we should at least have a bit of a conversation about that. So those are 2 things just to land, and it deals a bit with what I might have said in my report.
Stephen, thank you. I think those are both very good points. Does anyone have anything to add to what Stephen said, or anyone feel like supporting what Stephen said? Jane?
I think it is covered in the performance paper.
I know
we'll cover some of that in the performance paper later on.
Okay, and Teresa?
Yeah, just on the linking it to our previous discussion, I'm not sure that we actually have data about the impact on our recruitment and retention. We may have for retention, in terms of some of our really poor performance around EDI. That's demonstrated through our res data.
Jane?
I think it comes to more than just our res data, actually.
I think it does.
It's Bushra's point from earlier around where we've got a big system, and so we've got data from one part of the system and not from other parts of the system, which is actually what generated the assembly in the first place. The purpose of the HMY assembly was trying to have voices represented from across all our system, and that does have an agreed work plan that we're working to, which does cover some of the things we talked about this morning. Each organisation, however, has got its own, hasn't it? You've got your own, Jonathan, and others have got their own, and they can report on how that's going. Notwithstanding that, there's way more that we can do and should do, I think, is what we probably all are saying and agreeing with. But that is in existence and is there.
And just on this point, I mean, go back to what Jane Haslegrove was saying. I mean, there is no doubt, I imagine, an awful lot of action, if you like, going on in all of the organisations across across the ICS. But it's this point about, can we have some sense as a system about the impact of that? But yeah, thanks.
I wonder if we could just ask the executive in one of their meetings just to talk about this, please, on behalf of the board. We talked at the end of our Diversity Essentials session about what it is this board can actually do. or something that we could actually do is put this on our BAF and pay proper attention to it. That's something we could
I think this is really important.
So why don't I just ask the exec, please, to look at that over the course of the month ahead, and let us know next month what your decision was. And if your decision is that you think that's something we should do and that's a way that we could make change, then let's have it in the BAF for next month, please. If not, I mean, very interested to hear your views on that as well. But let's see if we can do that. Thank you. Okay, and now we're going on. I'll stop jiggling around with the agenda now. We're going to move on to item 9. This is the Chief Executive's update. So over to you, Steve.
And you'll be delighted to hear there's only 3 things, and I'm going to hand them all over. But just so the first one is just to Anya to just outline the background to launching our first phase of engagement on our calling the blueprint, but on our strategy, and obviously its connection to the government's intentions around a 10-year plan. So we'll go there first. I think we've got a couple of slides on that. And then I was going to ask Nigel, there's some new guidance out on freedom to speak up. So I was just going to ask Nigel to pick that up. Yeah. 4 things, I'm sorry. And then to Simon, if I may, just a quick update, which I'm very keen to keep on in our eye line here, on the primary care pilots. And then Jane, back to you on the staff survey, which I think we want. Okay, yes, that's specifically the staff survey for the integrated care boards. So to Anya, if that's okay.
Thank you. Thank you. And have they got the slides? I'll start talking while we get the slides. So Stephen alluded to, and as we've talked before, obviously a lot of work has been happening, particularly through the System Leaders Forum, in terms of design for the future blueprint, in terms of setting a framework and some principles for the direction of travel for our system. So we wanted to take the opportunity to start testing some of those principles around what we think really matters, obviously with the public and wider stakeholders and our wider staff base. So we have been planning this programme of work, and particularly this, as we're calling it, this sort of pre-engagement. It now very neatly fits with the national picture, and colleagues will be familiar now with the launch of the Darcy report, which I think we're sort of loosely describing as the diagnosis, and then the prescription, if you like, will be the 10-year plan, for which an extensive programme of national engagement I'll say will commence. I think a small element of that has commenced, with the public engagement happening a little bit later on, probably through later October in November. But we're plugged into that working group, so there's nothing that we're planning to do that is misaligned in any way to the national programme. It all dovetails quite neatly. I'm not sure we can find the slides, but I will just talk through the approach. So what we want to do, and it's very helpful actually that there's been obviously a lot in the media, particularly off the back of Darcy, is really having, as we've talked for a long time about, having that more open and honest conversation with the public about some of the challenges that we face both now and in the future, and how we want to work together to address those challenges. So we've framed it from a creative approach, if you like, in terms of positioning it as right in the next chapter of the NHS, with again those key stakeholder groups, the public being one of them. We know that the public are hugely passionate and proud of the NHS, but we all understand that challenges are leading to low levels of public satisfaction. So we want to have that honesty around what is contributing to some of those things, and how we can obviously work together to make it better. So that's how it's going to be positioned. I would have shown you some of the creatives, but I don't think we can quite get them on screen. Oh, we've got them, right, sorry. So you won't be probably able to read this, but it's setting out that case for change and the invitation, as I've just described, for the public and other stakeholders to work with us. We will be sharing some of what we think matters, but we want to test that obviously with the public. Emma, if we can move back one, please. So the idea is that from here on in, really, we have this creative approach that is what we describe always on. So this is helping the public to understand the journey that we're on, in essence, in terms of some of the challenges, some of the things that are working at the moment, some of the things that we want to test out. So from a visual perspective, it is likely that our public, our wider stakeholders and colleagues will see this. I'll go on to it in a second. Really, at least until the end of next year, as we work, as we develop the story and the narrative. But in particular, from Monday, we will be launching this focused period of pre-engagement, which will run for a month. And in particular, we will be focusing on the wider marketing and PR, as I've just described, stakeholder engagement, internal engagement with our colleagues, and in particular, the public engagement piece. If we can just move on one, and I'll just whiz through the next few. So this is just the concept of how the creative will look. Colleagues are working really hard this week to actually capture real stories. So the visuals that you will actually see from next week will have those authentic voices representing our colleagues and our members of our communities, talking about what matters to them, what they're concerned about the NHS, both now and in the future. If we can just whiz on a couple, please, to this one, thank you. And as part of that pre-engagement, we will be asking having a conversation and asking a range of questions. There will be a longer form survey that we will be encouraging all of those groups to complete, but in particular the questions will be themed around these areas. So as I've touched on, exploring the case for change to help people better understand why we need to change both now and in the future, and what some of those key factors are, ageing population as an example being something that we need to draw out more effectively so people understand that. Really getting into what really matters to people in terms of the NHS, and this, I will really stress, this isn't about coming up with a huge wish list. This is about having a focused and constructive conversation to understand what matters most and what are some of those key priorities, both in terms of services and access to services. And then exploring that further in terms of how should services perhaps be delivered in a different way to how they are today, and we'll be exploring things around elements that we know are really important, like transport and travel, in terms of how far people are prepared to travel for particular services, what services there would be more opportunity to use via digital channels, etc. And then finally, a theme around empowerment and self-care. So you can hopefully see how this aligns perfectly with the government position as well. So that will start from Monday. So I guess we're looking today for the board approval, endorsement on that before we actually pull the trigger, so to speak, from Monday, when this will become live with our public and stakeholders.
Just before you go to that, acknowledging you handled that very well with the technical difficulties. Just to make the additional point that in the spirit of the way that we're working as a system, our expectation is that all our partner boards will be carrying the same conversation through. We just
interesting. I was just going to ask that. I was going to say, what does it mean for Jonathan? What does it mean for Brent?
Well, they may wish to comment, but that's just so it's understood that that's how we're doing this. Thank you.
So does this paper go to the board of all our other trusts, for example?
Yes.
Okay, and it would be a board item for all other trusts. All right.
Yeah, so we use the blueprint pre-documents for board discussion. So we're taking the boards on the journey.
Okay.
Yeah, that's
using
a
this
good
or
way.
not using this?
We will use this. Shall we use the last set of documents, which was the original vision for the future, the concept document. This is a new piece that clearly Anya and the senior leaders talked about when we were together in York last week. So we'll now bring this into. So we're keeping that two-stage conversation going through
providers.
It's probably an important point. I mean, just picking up point about the journey. So this is the start of quite a sequence of things that will be running, hopefully like the words through the Blackpool, proverbial Blackpool stick of rock through all the boards as we go through this next few months. That's the intention.
Okay, lovely. Jonathan?
Yeah, just from a local government perspective, will we be looking at doing it through health and wellbeing boards? Will we do it via health and care committees which feed into the boards? I'm just wondering at place level how it will get disseminated.
Yeah, just to get into the practicalities. So I think there's actually there'll be a letter in your inboxes that will be going out to all our stakeholders, and there'll be a link to the toolkit. And what we're asking at this point is that those materials are disseminated through your organisations in the.
Just how we follow that up to make sure they get disseminated.
Yes, and if I may add, just an important question that of course our plays directors are quite important in that context, in carrying the flag, so to speak, in the way that you're describing, Jonathan. I should add, perhaps just for completion, that I know we quite haven't bottomed this session, but we've had a very constructive letter from our local authority chief exec colleagues about engagement with them and so on. But I mean, and that will be happening sometime in the next 4 to 6 weeks in order to carry that forward. And of course, as this sort of starts to develop, I think we need to be able to respond to what we hear and what might come in terms of active requests, which I think it's fair to say, Anya, we're gearing up to do.
If I may, though, Chair, I think sometimes there tends in the past been some cynicism. Oh, here's another publications from the NHS and involvement, and people saying, oh, here we go again. It's making it a bit more lively this time, I think, and we'll have a role in positively promoting it rather than being just another directives coming out of the NHS or perceived that way, I think.
Okay, thank you. Words of advice? Wishes.
I just wanted to ask, how does it fit in with the national kind of picture? There was the consultation on the NHS constitution. Is this going to feed into that? And are we confident that it will be work that was worthwhile and will be listened to in that national picture?
So I would answer that, if I may, by saying the Secretary of State and I guess the national team are really keen that integrated care boards act as the convener for just that. So I think the short answer to your question is yes.
Yeah. It's very fortunate or utterly brilliant management that these two things fit together so very, very well. Brilliant management. Let's see.
Yeah, thank you, Chair. As you know, I'm the Freedom to Speak Up Guardian for the ICB, and we've got arrangements in place for all of our providers. But one of the areas that we knew it has been a gap for many years is primary care, and not only primary care GP, but the contractor groups with primary care. So this month there has been a letter come in from the centre to talk to us about how we start to ramp up that offer to our wider contractor groups. This is something that we already started to do, and what we'll do is formalise that over the next few months and make sure that it extended out to those other contractor groups. So it's just a flag to the board that it is in place and it is expanding, and that is in keeping with the letter. Just actually to go back to your action point, if we don't mind, is that you're absolutely right that for our freedom to speak up, we found that 90% of the freedom to speak up was from women and from minorities. Actually, when we've asked wider in our system, those demographics are not asked for, which is interesting in itself. So it's something that I'm going to take on a sort of back to the network of northeastern Yorkshire about how we can maybe get that data, because from what we learned earlier on, I think it's really key that we get that data and understand it.
Okay, thank you, Nigel. Item 3 is Simon.
Simon next.
So just to get an update on the PCN national pilot. So it was, I went to the launch meeting earlier in September, and it was quite interesting because the Claire Fuller started the meeting by saying this is the most exciting room to be in the NHS today, not least because you're the only people in the NHS who are getting a little bit of extra money to try something out, which was almost certainly true. So just a quick recap: this is a national pilot sponsored by NHS England and 7 ICBs, 22 PCNs, 1 million patients across the country, of which we have about 130,000 in 4 PCNs in North East Lincolnshire, in Whitby Coast and Moors. So I declare my interest as a practice partner in one of those, in South Hambleton and Rydale, and in Holderness Health PCNs. It will run over the next 2 years. It started properly on Monday with a data gathering exercise, which is what the next 3 months are all about. And this is really about a massive time and motion study, asking all staff working in general practice in those PCN areas exactly what they did all day, every day, including the days you're not supposed to be working. You still have to send in a return. And it's about how many hours you've worked, how many patients you've seen, how much was digital, how much was face-to-face. It's a massive study. What then happens from January is that all of those PCNs will start to undertake continuous quality improvement in a number of areas around the operating model of how they manage all of the demands. And they can choose what they do. There's the potential also to choose some digital tech. So Max and I have been having conversations about how we as an ICB might support our 4 sites to do some of that. And they then undertake continuous improvement, whilst then continuing every few weeks this time and motion study to see what seems to be changing, as well as all of the other richness of data that we know exists within the GP clinical systems that can be extracted to look at an objective view of appointment availability, of achievement of things like QOF and clinical outcomes, admissions to hospital, all sorts of different things to see what difference it makes. And the questions NHS England are trying to answer with it is, how are current resources in practices and PCNs used? What is the current gap? Because they accept there is one between the demand and the supply that is funded. And how much does this money, which represents about a 10% increase on the value of core for those areas for 2 years, how close does that get to closing the gap between demand and capacity? And what's the most productive way to do that from the 22 test sites? The aim is that will then inform the kind of ideas around the national operating models that will feature within the reformed GP contract. 2 potential issues we just need to be cognizant of. One is we're doing this in the background of BMA's collective action, and therefore this was one of the 10 collective actions that practices were asked not to participate in. So there is a lot of noise about this. There's some unhappiness even within some of the participating practices, which of course are usually partnerships with multiple partners who don't necessarily always agree on everything. You'll be surprised to hear. But it is still happening, and but it is against that background. That then also leads into the political climate, which is that the pressure on the government to come up with a new GP contract, the timescales now don't quite fit. And part of that, of course, was because this was planned. In fact, it was that the initial first meeting was the day before the election was called. And if you remember, that was probably 6 months earlier than most of us thought it was going to be. And therefore, the timescales now are slightly out of kilter. So there may be too much political pressure to do a new GP contract before the end of this pilot. So the learning in real time from this pilot becomes much more important potentially than some report that may be published in the future about it. So we also have undertaken that we've promised to all of those practices and PCNs in our area that are not part of the pilot sites that we will share the learning as quickly as possible with them, so that if there are things that they can be doing, then they can start that rather than waiting again for some sort of national report. Next steps are complete this audit week, 2 more audit weeks between now and the end of the calendar year. This time in 4 weeks' time, we're getting a royal progress from Claire Fuller and Tim Briggs, who are coming to meet our 4 PCN test pilots for the first couple of hours. They then want to test out the real relationship between clinical leaders within our system.
Yeah.
So the invite, Nigel's helping pull this together, is to trust medical directors, to wider system clinical leaders, to say, if this is going to really make a change around integrated working, care closer to home, in the community, in primary care, what are the relationships? What's the evidence that you're going to be able to actually take this forward, do something with it? So no pressure, but we, those of you who, well, I say that, those of you who know Tim Briggs will know there'll be quite a lot of pressure on the day, but that will be really great. And it is forcing the pace to some extent on the idea of what the test sites will do. So it's all go.
Fantastic, thank you. Are we going to talk a little bit more about GP action later?
Yes,
we are.
in the
We are.
private session. Yeah.
Thank you. Nigel.
I think it's really good progress, isn't it? It's great. One thing I was just going to flag, and you might know it, was that our Ardens templates are on non-recurrent funding. So anything that you're basing your assumptions on has to be in part about if there is a lot of productivity out of Ardens, how do we recurrently fund it going forward? And for people that don't know, it's a bolt-on piece of tech that allows policies, pathways, and coding to be brought through. So just.
So I'm pretty sure it's one of the things in our proposals for strategic development funding, which perhaps more on later, but also we can discuss some of the details about the future of Ardens text. We've got John here helpfully, which is really useful because John knows all about that as well.
Nigel's being valued it, but Ardens definitely has value, doesn't it?
Okay, thank you. And item 4, Jane.
Yeah, thank you. This is so the NHS staff survey has been launched nationally, but you may remember that as an ICB we didn't participate last time, basically because we were doing the values work and we were already doing the survey around that. But this year we are participating, so it went live a couple of days ago. It'll have gone live across a number of organisations too. In the first 24 hours of it going live, 25% of the organisation have already completed it, which is really good news. And we want to continue that contribution because we need to know and understand what our people are telling us. It runs to towards the end of November. We don't get the outputs of that then till around January, February, and they go live publicly in March.
Really helpful. Fingers crossed. We made a big song and dance about it at the staff roadshows, really asking staff to complete the surveys, and I assume that's going on in your trusts as well, and in other areas. It's well, we were talking this morning, weren't we? Information is a slice of time only in some ways, but it's better than having nothing, and it will be useful for us to do this survey. Stephen, anything else?
No, nothing further from me, Chair. Thank you.
Thank you. Jane, that takes us to Jane Hazelgrave. Item 10, the performance report.
Thank you, Chair. So you've got the cover paper and the actual detail of the performance report in the supplementary information. I think we'd all agree that we've come leaps and bounds in terms of the presentation, the detail that sits in this paper. It's just it's really extensive under each of the indicators. So just to let everybody know, this particular paper is about the annual operating plan, the objectives that sit underneath that. And then we've got a summary slide which sets out the 10 primary indicators that we focus on, that set out, I think it's slide 3, and also I'll just hold it up if you look at those. So of the 10 indicators that we particularly highlight, you will see that we're just delivering from a plan perspective, 4 out of the 10 we're actually meeting the plan trajectory. And the interesting one, I think, probably is, if you look on that page, is urgent and emergency care, which interestingly in August we were meeting the 4-hour performance. And I think Stephen talked about in the preamble that actually September's been a much more challenging month. So in terms of August, the ICB was delivering 73.3%. And from the acute bit of the system, they're delivering 68.2%, so deliver at 68.6 against a plan of 68.2. So although we're delivering it, I think we'd all agree that the urgent emergency care system, I'm sure our providers around the room would say that it's particularly hot at the time. On planned care, even though the particular indicator we're looking at is the 65-week waits, and although we're not delivering that, we are probably the best in region, one of the best systems in the country. And I think so the paper here sets out the position as of July, which is that we did that the 65.
We were being acknowledged in the regional meeting last week as being the best.
Yeah, we are best in region.
It's very worth noting. And
Yeah, so plan July was 95 and we're at 147. I can say September we're down to 48, although the plan was to deliver 0. But notwithstanding that, it is actually, like I said, the best position in region. And again, from a diagnostic performance, this particular indicator, we are actually delivering, Stephen, but there are risks associated with diagnostics, as you have described. So the monitoring of the diagnostics is the percentage of patients waiting over 6 weeks for the 9 tests. And of July, it was 21.4% of patients waiting over 6 weeks against a target of 23.7. So we did actually achieve that. Cancer, I think, is we are not delivering the cancer target, and I think cancer performance on the page, if you look, there's a tracking over the last few months is variable, and we were delivering it, June, but we're not delivering that performance as of July, and the July performance is 63.8 against a target of 64.3. And if you look in the report, there's lots of information that sits beside underneath the cancer performance, a wealth of information there, but that's just the headline indicator. The primary care indicator that we've got in terms of number of appointments, we are delivering. That's one of the ones that we are delivering. So that's great news. And then the next one is prevention and health inequalities and percentage of patients with hypertension, not met for the last 2 months, as you can see on the report. The community indicator that we'll look at is the number of community services waiting over 52 weeks. And although we are delivering on plan, I think there is some challenging under that. If you look at the report and indicators, there's a wealth of community targets that sit underneath that. The headline we are delivering. And then the 3 mental health targets not delivering. But I will say on the inappropriate out of area, we're just a smidge, if you like, away from delivering that. So that is good news, and it is significantly improved. So I think that's probably just worth pointing out. I'm not going to say anything else because the report has got so much information. Those are the headline indicators we've set them out, and I'm just wondering if I'm quite happy to take questions from anybody.
Questions for Jane, please, in respect to performance. Jonathan.
So it's more a comment just in support, Jane. So we're still working to as a system and anticipating 0 65s by the end of this month.
Okay.
So we haven't kind of stopped the effort.
Okay.
We got to 40 odd, we're still running for the line.
Yes. Okay, thank you. Jonathan, Charlie and then Louise.
Thank you. This is not directly a comment. It's something a bit deeper, I think, about prevention and health inequalities.
Mm-hmm.
Is it both of those things separately or together? I'm not entirely sure what we're after here. Are we after prevention generally, or prevention in relation to the prevention of health inequalities emerging? And then there's the indicators. Hypertension. I'm sure it's a very, very important indicator. I can't comment on it, but it's not an indicator of general progress on prevention or health inequalities. And the subsidiary indicators, which are mentioned in the detailed report, which the Population Health Prevention Committee looked at, for vaccination updates, uptake, and core 20+5 approach for adults. Again, they're isolated things. They're not about a strategy for either prevention or the reduction of health inequalities or the interaction between those two things. I know lots of these things are handed down from above. But I'm wondering whether what's handed down from above is good enough, whether we should be thinking more systematically, I'm sure every ICP should, about how we move more decisively into a prevention space with a focus on health inequalities, so that we don't end up with all of these nasty big negative indicators that we report on each time.
Yeah, thank you. It's helpful, Charlie, and I think it reflects some of our existing thinking, actually. So Louise first, and then I might say a word.
There's a real segue into what I was about to say, Charlie. We had a conversation at the Top Health Board last time, particularly around CVD. And in its broader sense and thinking from prevention. We actually discussed it in the context of the BAF. You were pleased to know, Chair, that we were discussing the BAF, whether or not we needed to think about escalating any of the issues. We felt there was some additional work to do offline, to think particularly around cardiovascular disease, because this is just one indicator in a whole suite of things that we could be looking at. But I think it links very closely to the work that we talked about at the ICP and the work that Jake is developing. So I shall hand back at that point in case that's what you were going to.
And that segues exactly to what I was going to say, which is I think we need to do much more work around our integrated care partnership, strengthening our integrated care partnership, which is the home of our strategy, and should be the place where we monitor our achievement against strategy. So we accept your challenge, Charlie, and it's in our thinking.
Can I just come in, just in terms of Charlie? I think you are right. So the very beginning of this. The introduction to this is the annual operating plan, and there are 32 indicators, and we've just aligned them under that. I completely agree with you about that longer term strategic piece. But these are the things, whether you like it or not, that we get measured against. Our single oversight assurance framework will measure us on it. Yeah. And I know we've used it, the headline prevention, health inequalities, and the indicators sat underneath that. And there's quite a lot actually in the paper. But we're sort of like trying to almost like get the 32 and squeeze it into our plan in a way that makes sense. And when I've done, we discuss performance reports all the time, what are your top 10 things that you're trying to achieve? What is your true north? We've talked about those kind of things before. And I think it's just that context, but I completely agree. Those are the things about that we need to do that are really important things. But some of the indicators are a little slow moving, aren't they? And these are the things that you can measure, they can measure. And that's just how it is, really. But I completely agree with what you're saying, Charlie.
Yes, Jonathan.
Sorry, can I just also mention, since we last met, both of my organisations, so two of our system organisations, and and Hull, were announced by the Secretary of State has been nominated as part of the Further Faster 20 scheme. So this is a direct recognition that we have working age adults of a lower socioeconomic income earning band that are currently claiming large swathes of benefits because of the amount of time they've waited for operative care in our system, and could otherwise return to employment workforce contribution if they were seen quicker. And both Hull and NWAG have been signalled as two of 20 trusts nationally that are going to get accelerated support from national colleagues, Tim Briggs with his other hat on and others. So we're actually receiving positively. So you could kind of adopt an optic of, we're slightly embarrassed by the length of our wait, etc., etc. We're more viewing of actually somebody's listened to the very challenged demographics that we serve across our conurbation, and we're seizing opportunity for that level of support. Thank you, Chair.
Thank you. I mean, just to tie in with the bit of conversation we've had about winter and Stephen's concern about urgent and emergency care. This is the August figure, which looks quite good. Do we know what the September figure is across the piece?
I don't have my fingertip, but I can guarantee you it's worse. I know that.
It's in the 50s.
It's two. No.
It's late 60s.
It's about 2% or so off. But if you look into, just to bring you right up to date, if you look into the last 7 or 8 days, it's worsened again.
Yeah.
So that's the point of my concern. This is the reported position. Just to be clear, what I was saying at the beginning is I'm concerned about looking ahead in that context.
Yeah.
So in a number of dimensions, like the ones I mentioned. Thanks.
So we note great concern around UEC. What I would say is, looking at the summary overview in your report, Jane, even where we're missing targets, we're close in most cases, aren't we?
Yeah, there's some improvement even the ones we're missing. So that is encouraging.
That's my sense. So thank you.
Lots to do though.
Loads to do. Brent.
So you'd probably expect me to just draw out from the paper in terms of the 3 mental health indicators and the SDN decision making, and that's what's going to push us through.
Yes.
That's subject to. We are getting close.
Yeah. Okay. We know that.
Is it, well, just because this is a public meeting, I mean, it's pedantic, but could we just say what SDF actually means?
Yeah.
In terms of, I mean, it's a general message, not just to you, Brent, what the abbreviation stands for.
Service development funding.
Service development.
Yeah.
Thank you.
Okay. Thank you. Nothing else for Jane just now. Thank you. Let's move on to item 11. This is the finance for Emma.
Lovely, thank you, Chair. So within your pack, you've obviously got the usual finance report that is an outline of where we are on a year-to-date basis at month 4, so at the end of August. Again, key messages outlined in the covering report. So at the end of August, we had a deficit plan of just under 61 million. An actual position of 61 million against a plan of 69 million. So a 2 million adverse position at the end of the month. That was entirely related to the impact of industrial action, and again reported within the body of the report. I can now confirm that at month 6 we have received the allocation that covers off that 2 million, and so that will show quite differently when we move into month 6. The same applies to the deficit allocation funding as well. So month 6, when we come to month 6, the position will look really different because we have also received the 50 million allocation, both from a revenue and a cash perspective. So we have got in part 2, part B, the...
I may, Joe, just a point of clarification. So I know so essentially with that's a balanced position.
Yes,
at month 6.
it is. Yes, yeah, absolutely. And obviously, again, as previously reported, the financial risk that we face in the second half of the year continues to be a cause of concern, and is obviously something that you, Stephen, have referenced in your report. So the other thing I was going to say is that we have had a lot of concentrated action from a multidisciplinary perspective. So we've had quite a lot of work going on, as we've reported previously, between finance professionals and workforce leads, HRD colleagues, over the summer, that culminated in a summit, a multidisciplinary summit on the 27th of September, which really has focused attention on some of the actions we can take to mitigate some of the risk in that second half of the year. There will be more detail of that next time, and we will go through some of that detail in part B. But just to say that the sum of those actions is somewhere in the order of about 20 million. Again, not without risk, but we have, I'm encouraged that we have got some real action that organisations within our system are committing to in order to mitigate that risk in the second half of the year. It doesn't mitigate it all, and we've still got to keep a forensic focus on this really as we move forward. And in terms of the service development funding, we have made assumptions because of the timing of the planning process that there will be natural slippage against the service development funding. We are doing some work by programme area to understand what options we've got in terms of the deployment of those resources in the second half of the year, with a view to releasing those as quickly as we possibly can, because of the challenges that we've heard sort of smattered through the meeting that we've had already. So in terms of other sort of key messages, from a capital perspective, you can see there within the dashboard, we're green on a year-to-date basis, but we've got a bit of risk forecast towards the end of the year. That is all around timing of receiving of allocation, and we're expecting that we will come back in on track on that. We will be picking up again much more granular detail around the workforce position and the triangulation between our workforce assumptions and the finance. Again, both in part B and next month, we are keeping a real focus on some of the agency and temporary staffing levels across our system, as you would anticipate. And I was probably not going to say an awful lot more than that at this stage, but happy to take any questions if anybody's got any.
Thank you, Chair. Let me look to the board. Any questions for Emma? Jonathan?
So it's just an observation, Chair, if I may, recognising that we're in public rather than private. So I think our landscape, when we're now starting to address the slightly less palatables, I would say. Yeah. So, we're taking our board on a journey of tolerating slightly more indigestible options to start to close that gap.
Okay, thank you. Simon.
So obviously just repeating my conflict of interest as a GP partner in a practice within our ICB area, but I am just going to clarify, and I have given Emma advance notice of questions, so I'm not dropping her in it, but the balanced position as we currently have it at the moment, does it contain an element of the SDFs, both in terms of the original amounts and potential and or potential in-year slippage, such that it isn't an automatic increase in our deficit position were we to commit SDF for things like winter planning or mitigation of collective action in primary care, for example.
Yeah, no, thank you, and thank you for the heads up in advance, much appreciated. So yeah, as I sort of said in my opening report, we have made assumptions around natural slippage because of the timing of the notification of the allocation. So if we were to push the button on, releasing it all, there's only so much you can do at this stage in the financial year anyway. So the answer to your first question is yes, we have made some modest assumptions around what that equates to by programme area. We haven't taken a view of any benefit of a further saving on the back of any action that we might take subsequent to that. That isn't to say that we've mitigated all of the risk. However, we've got some, as you'll remember when we look at the bridge analysis, we've got some key junctures in our next 6 months that we need to mitigate, and one of those would be unused allocations, further slippage on investments, for which SDF may fall into, but we haven't at this stage banked on or locked in any further saving ambition.
Thank you. I think it's important, as we've had that exchange, to just remind ourselves that in the plan for this year, it was always the plan to release that funding subject to the delivery of our plan. Yes. And lying behind your eloquent description of where we are is in order to release some of that funding, plays to Jonathan's point, some other decisions need to be made to support that. So I just want to make that point. It's not without consequence, but it would be, the point is that was always our plan, and it would be the expectation of NHS England that we do that.
Yes,
so, just to make that point. I mean, I think that's the accountability responsibility, if you like, that in this particular context that we have.
Can I just turn to Richard Gladman? Richard, is there anything from your F&P committees that you'd want to raise following Emma and Jane's pieces? Is there anything you think the board should know?
I think it's worth probably later on dwelling a little bit more on your summit and your get together and the next steps that come out of that. I think we can probably pick that up a bit later. I'm also interested, perhaps a bit later as well, in unpacking the relationship between our workforce situation and our finance position. I did note in the performance report on workforce, we've got about 700 FTE negative delta. Yeah. So we've got a higher position than we were forecasting, and clearly that will have financial implications. So again, that's an area that we'll be exploring in future FPDs and also probably a little bit later today.
Okay, thank you. Stephen.
So just a very brief comment, as you've raised it, and it does connect to what Jonathan Lofthouse was saying. Really, the mitigating actions to address those things you talked about, there are some that are not, but they're significantly about workforce. In every organisation, including the Integrated Care Board.
Okay, thank you. I think, unbelievably, we're just marginally ahead of ourselves. So I think we'll probably go through the committee summary reports now before we just take a quick. Oh, sorry, you waved, didn't you?
I did.
Yeah, really, absolutely unintentional, Stuart. On we go. Go on.
I was just going to thank Emma for a bit more detail on the capital programme. I've asked questions about the capital programme for a while, and in section 6 of the report, there's half a dozen bullet points that remind us that we're spending quite a lot of money in investing in capital items that will improve the service. When you don't improve it instantly by building new stuff, but nearly 63 million quid on various schemes that will essentially improve the service that we give. And there's talk about the money we're spending at Catterick on that great new service there. So, so I just thought that was worth thanking Emma for, because it's the sort of descriptive addition that I've been asking for a while.
Thank you, Stuart.
Yeah, it's remiss of me not to mention this at the beginning, because the sort of bigger context here, whilst we're just on the money is the budget at the end of this month, and then furthermore the comprehensive spending review next year. And I maybe Jane will remember this, but I mean one of the plays in that from a National Health Service point of view is a really significant slug of capital. You know, a large amount of money, and this will be all the dynamics with the Treasury. But I don't know that that in year 24-25, and I don't think we should plan on the basis that there will be anything to alleviate the pressure. But it's clearly a high profile issue for the government. I think if there is, it'll be targeted. And there'll be strings attached, I imagine. But I think it's important to land that, because by the time we meet again, we'll have at least heard the first part of that sequence.
And I suppose just to come back on that, so yes, I think in the description that it's the shortfall of 37 billion, isn't it, as an explanation of some of why the challenge we face. But I think it very much connects to the design for the future piece and the blueprint. You know, we need to be really, really clear as a system what our strategy is and where we're going to target any capital or revenue resource that does make its way into the system with the biggest impact.
And it should support those three big shifts.
It should support those big three shifts, and it should also, you know, look at the broad system capital and estate portfolio that we've got. And I think we're pleased to report that it feels like we're ahead of the curve with the work that Pete and Steph Porter are leading in terms of that proper utilisation piece around some of our out of hospital estate and how that connects to the hospital provision as well, really. So yeah, welcome that as a big feature.
Okay, thank you. Shall we just look at the committee reports then? And if you remember, and I've been reminded this week, the committees do the work of the board. We delegate responsibility to these committees to do the work that we simply haven't got time to do at board. So these are formal committees of the board which report back to the board, and their purpose is to provide us with assurance around their specific area. So the System Quality Group had no alerts for the board, but the Quality Committee did have an alert for the board for escalation regarding urgent and emergency care. Is that to you, Mark?
Yep, that's over to me. So yeah, I mean the report is there. I won't talk through it in any great deal of detail, but I do want to highlight a couple of things. I think the key thing around urgent emergency care, you know, is not a surprise to us. We know there are performance issues, but I think the thing that was important is we wanted to look at this from a quality of patient care perspective as well as hitting the operational target, which is a concern. So this will come back to Quality Committee on repeated occasions. We were particularly interested in things like the impact of ambulance handovers, and also the opportunity of looking at intensive users and making sure that they got the best sort of care, but also that created space for others to get care. So it's just to highlight the fact that we're talking about it in that committee as much as anything, because I know this is not a surprise to this board. There were just a couple of other things I just wanted to highlight really, really quickly. Was we are going through a large number of health optimization related policies. We went through 57 at the last Quality Committee. Bearing in mind there's a lot of background work that goes into these. We will be picking up the second slice of these at the next Quality Committee, which will perhaps be the more challenging ones to take decisions on.
Okay.
So we will report back to this board accordingly.
Okay,
so it's just important to highlight that. We also signed off the report on complaints, comments, concerns, etc. So that's important to highlight. And I think the final thing to highlight for this board is that where we've had significant issues like the prescription or otherwise of sodium valproate out in our wider system, I think it's highlighted to us that we need to continue to focus on when we have made a collective decision, that being implemented out there, all the different parts of our system, all our GPs, QTRUS, etc., in a consistent way. So again, that's something we will focus on moving forward. That's all I wanted to cover.
Thank you both. Workforce had no alerts. Pharmaceutical service had no alerts, but clinical professional had one alert. Nigel.
Yeah, well, it links very well with Mark's previous comments. So, as you know, we set up a clinical effectiveness unit, which is really like the clinical policy unit for the ICB, which is harmonising all the policies and pathways, and it goes through the quality committee for ratification of the process. What we're finding, though, is how do we share those clinical and policies and pathways wider, and what do we need to do about that? We have had some work on this actually, and hopefully over the next couple of weeks we will be able to get to a solution. But it's just something to highlight to the board, that actually a lack of a digital repository that everybody can look at and draw down those policies and pathways will stop us from sharing good practice across the board. And sort of links in with sort of Simon's discussion are really about when Tim Briggs that comes and talks about it, we'll have to talk about what our direction of travel is, and this is going to be a key point of that, is getting everybody to do what we want to do through that clinical effectiveness units and policy unit.
Okay, thank you. Good. There are 2 alerts from the Integrated Care Partnership, which I chaired just a couple of weeks ago. One was around a proposal from Charlie. Do you want to elucidate, Charlie?
Very briefly, thank you. Yes, we've been working on a second project following on the Children and Young People's Project, now known as Connected, Humber, North Yorkshire. This focused on the other end of life, so ageing well in our language. After much deliberation, we have come to a focus on care with a strong technology component, with a view to emulating at least some of the approach taken in Plymouth in establishing a living lab around technology and care, working with a major social housing provider in Plymouth. There may be equivalent opportunities here, with a focus on 3 coastal communities, recognising that coastal communities have distinctive features and distinctive health challenges. Scarborough, Bridlington, and we couldn't separate them, so we're going to call it Grimsby stroke Cleethorpes, across 3 of our local authority areas, therefore. Latest update on that is that Phil Metham, who's been helping us to coordinate this work, spoke with the chief executive of the new mayoral combined authority in York and North Yorkshire yesterday, and that mayor is really enthusiastic, recognising the various benefits that could emerge from this for the agendas that he is pursuing across that region. And since we will have a mayor in East Yorkshire next year and in Lincolnshire in some form or other at some point soon after, there may be growing opportunities to connect across different parts of policy and public sector in due course.
Thank you. Thank you. Any questions for Charlie? Yes,
it's just a point, and Charlie knows this very well. I'm sure that the directors of adult social care be really keen to be briefed and included in the work, I'm sure, because care is obviously provided through local authorities as it currently stands at the place level.
Very strong place component in all of the thinking.
Yeah, thanks.
Okay, lovely. You're leaving us, Jonathan, nearly. And just to say that the other thing the ICP discussed and had quite some presentation around was the nature of patient transport across our geography. So an item of great importance to individual service users and patients. So a lot of work completed already, but not yet fully completed. So more to come on that. But that was an important issue for that group. But we've managed to be a little bit ahead of ourselves. Utterly extraordinary, I know. Why don't we just have a 15-minute break now? Just time for you to do what you need to do, but back here, please, at 12:30. Thank you. Very, very good. Well done. Are we in public now? Okay. So welcome back to part 2 of our board meeting held in public. We're on to agenda item 13. This item is with Jane. Jane Adamson. We asked for an update on the breakthrough programme to the board. This is our workforce programme for the year or two ahead, Jane, isn't it? So can you take us through your paper, please?
Certainly can, thank you, Chair. So you've got a paper in front of you that is working through 3 things probably in total. One is exactly what you've asked for, so it gives you an update on where we are against our breakthrough programme, and in Appendix 1 you can see the detail of all of that along with what the plan was and where we are against that plan and any risks that we've got in the plan. I've also pulled out in the paper a spotlight on 2 or 3 different areas that I thought would be helpful to focus on, and we can do spotlights on other areas if people have a particular interest in them at future meetings. I thought it was also worth bringing people up to speed with where we are on the OD&T plan for our own ICB, and Pete's been helpfully presenting the work that me, Pete, Anya and Karina have been doing around the roadshows. So some of the people that have been at the roadshows will definitely have seen that, but I'm pulling out some highlights around that, and then just shining a light on some of the activities that are going on in the HR team in the ICB particularly, and the volume of work around organisational change. There is a particular request of the board today around our proposals for talent management and leadership development, which I talked a little bit about yesterday at our development session, which maybe will help the focus on the conversation in the paper. So I'll probably start with that, if that's okay with everybody. And the talent management work stream is also a work stream within our breakthrough programme. So it's one of the work streams that we have. And we've developed 3 opportunities for leadership and talent development across our system that will be ready for launch varying times from early 25 through to the first quarter of 25 next year. And we've been doing some work also behind the scenes in shaping what that might look like and making sure that we've got some internal resource and capacity and funding to deliver against some of that. So the 3 schemes are a whole system high potential talent scheme. This is a system-wide scheme, but in the paper I've referenced in NHS terms the bandings that we're trying to target with that. So from band 7 up to band 8C. And we want to do that in a really inclusive way. And we've already practiced some of that inclusive way as we've recruited into the associate non-executive director roles that we've had. And what I mean by a more inclusive way is making it lighter touch in terms of the applications, and therefore and promoting them in areas where we wouldn't normally. So this isn't things that will just go on NHS jobs for people to apply for. This will be much more targeted, and people will be able to apply through expressions of interest rather than the full formal recruitment process that we would ordinarily do. And that's purposeful to try and increase some of that diversity of thinking and some of that capability in that high potential talent scheme that will be our talent of the future.
Jane, we'll be running that internally, will we? This is our managers, leaders, trainers delivering the training.
Yeah, yes, it will be. Yes, yeah. There's a small offer from the Leadership Academy, so we'll be tapping into some of that offer. Again, that comes without cost. So there's some modules that are done through where we already know there is some expertise, but predominantly that's going to be delivered ourselves. Yeah. We're also proposing a whole system executive level leadership development scheme. We do already have the NHS aspiring executive scheme, and we've got 27 of our people across our system on that scheme. And there's 2 cohorts of it already. That I think there's an imminent 3rd cohort. We want to do a full system though. So the one that already exists will fit within that broader spectrum, because we're trying to attract people from across the whole system, and particularly around system level leadership, which can be different to leadership in an organisation. There's some similarities, but there's some differences. We do have and know that we've got some challenges because there's already national work going on around some of the things that we want to do around the leadership development scheme. And that might, we don't want to slow down what we're doing. So we're going to still continue and develop what we're doing, but we're going to have to look when that comes through at what that means for us in our system and in our integrated care board. And then the last one in that is the development programme for internationally educated colleagues. And that's come up both with through the Inclusion Assembly in terms of what the lived experience is like for people that have been recruited internationally in, and how sometimes they don't feel that they're appropriately supported in their roles, notwithstanding the organisational efforts that go into creating some of that. So we want that to be a better connected experience and a proper peer group wrapped around those. So that's the talent piece. Other than to add on.
Sorry, Stephen just wants to interrupt.
Can I just really make a connection with our, not everybody was there yesterday. So I'm sort of deferring slightly to Nigel, Usher and Simon on this. I think there was a point yesterday, is that there's 2 points really, just to connect it up. There's the primary care leadership point, and I suppose within that sort of talent management question, and the broader clinical leadership. So I just wanted to flag that, Jane, that I think it feels to me that that's a really high priority. System wise, and particularly with our specific responsibilities around primary care, to make sure that's really embedded fully. I mean, I'm sure there are elements in there already, but it's a direct action from yesterday, really, just to emphasise. Thank you.
And I think, Jane, you should consider this board as a resource for that training and development. I think it's probably in all of our job descriptions that we've got a responsibility to support the development of others. And who knows the system better than this group? So please don't hesitate to invite us to contribute or, to practically, if that's at all helpful. I think it is a responsibility of the board.
It is really helpful because 3.4, I'm referencing, although we don't need any funding in order to run these programmes, we do need a commitment from this board that this is of real interest and this is what we want to do. And that will include time commitment as well as what we do when we get to the medium term around this, because that might lead us funding.
Only just 1 point, if I may, I know to labour the point, but I don't know how we address what I've just said without some cost, whether that's direct cost or releasing time cost. But I think that's in the detail.
Fair point. Do you want me to stop and ask if people do support that at this point? And then I'll just keep moving on. Yeah. Okay, brilliant. Thank you. Excellent. Which one point? Sorry, no, I thought you'd put your hand up next to me. The next spotlight is on the pay bill and agency management. Now, this was written before we had the summit, so there's further work I know that we'll discuss later this afternoon about what's come out of the summit. So that's not referenced in here. But there are 2 main areas that I have referenced in here around what we've done since we've set up, notwithstanding that we've got the pay bill and agency management plan. I do want to draw people's attention to the dashboard that we've developed, because that is as real time as we can get it now, actually, which is normally the workforce data is about 3 months behind where we are now. The September data, so September closed last Monday, will be loaded at the end of this week. So we're pretty close to your finance streams now, which is a significant piece of work, and it does give a lot of information. Some colleagues will get to see more detail of this because we've got a separate session to take you through what that dashboard looks like. The couple of areas that I did just want to tease out was around medical agency rate card and the roster development. So while we've got reductions in agency whole time equivalent, it's still costing us more because predominantly it's about agents, it's about the medical staffing, which their rate card, if you like, is higher, which is causing us some challenges. We do have an offer from the Workforce Alliance, who are part of Crown Commercial Services, to support the development of a single system rate card for medical agency. So we're working and shaping that up, ready to go into the next PAM committee in October. And then, so that's about the cost. And then there's the availability. So the next bit is the roster development and how critical that is. Both of these are really 25-26 delivery and not 24-25 delivery. So it doesn't help us with our some of our current challenges, but notwithstanding that is incredibly important for us to be able to get to a point. So from the 1st of April next year, we're delivering against those. And then we're actively working to examine the scaling opportunities across the system. So we've got support through the Acute Collaborative finance lead, who's been helping the committee to understand where some of those opportunities will be in an evidence-based way, and that's coming to the next PAN committee in October. So we can look at that and make some decisions around where we would want to progress with scaling. And the last point is really that the Grant Thornton work, the rapid review that they've done, notwithstanding we wrote this before the actual summit, there was nothing that was coming out of the Grant Thornton work that we didn't already know that A, we needed to deliver against, and B, that we had in plan. The question might be how we can go further faster, really, but that is already fully highlighted in that work. That's it on the pay bill and agency management.
Obviously a critical area for us, something we're going to be discussing later this afternoon. Is there any further comments about that now? Thank you, Jane.
Okay, last couple of areas then. One is the Breakthrough ICB full programme launch. It's officially known as OD&T, but it has it's linked into the system work in some way. So some of the programmes are using system work to deliver them. So on the back of the values work that we did, we've been working quite hard at looking at what that programme would include, and that's been around developing what an agile ICB would look like. And on here you have over the page and in figure 1 a breakdown of that breakthrough ICB programme outline. And in the green are the people programmes, if you like, and in the orange are the strategic transformation programmes. We do have identified leads for every single one of these programmes. They are in different stages of development. So some are quite well established, some are in the early stages of establishment, and the first meeting is this Thursday of the leads of that programme, and that's the governance area. So they'll meet with myself, Pete, Karina and Anya on a fortnightly basis, as they develop those programmes. I think that's probably all I would say on that, unless people have got questions on.
Does much of what exists in the green column, much of what's in the green column already exists?
Some of it does, yeah. So the coaching network, for example, is established, up and running, and it is working. The health and wellbeing offer is more or less complete. I think I've made a comment on it at the bottom in here around at the health and wellbeing offer, a low-cost ICB organisation offer drawn together that's pulling in some different elements. So that's up and running and just about to launch. And where else have we got? So reward package is about probably halfway through. We're still working on the recognition programme. So there's a number of things that are fairly well established and a number of things that are at the beginning of their journey.
Jane, just to build on what Jane's presenting, I know we had some, I get it connected yesterday to today, but I think it's quite, and indeed the staff roadshows, 6 of which we just, which covered this ground, didn't it? And I think I'm mindful of something Teresa was saying yesterday, that we are designing an agile organisation, but our expectation is that organisation, the ICB, will be smaller. As a result, I'll put that sort of on the record, and by that I mean some of this is about the movement of functions more sensibly, whether that's to place or whether it's to collaboratives, whilst we streamline as efficiently as we can those things that only we can do and should only be done once across the whole system. And I think the paper helpfully outlines the sort of areas of focus that we're honing down on. So just I mean, and the reason I want to highlight that is that's going to become probably over the next 2 or 3 months some mainline business here in the boardroom. So I just wanted to make that clear as we go forward. Thank you.
Thank you. Any other questions on that? And I'll do my last bit.
No, I do have a question, Jane. There are 3 things in that green column which start with agile working. Does this mean we're going to have a policy on what we actually mean by agile working, as in work from home, in the office, all of that stuff? Are we going to finally go to that?
And is the SRO for the agile working. So I'm going to nicely segue.
So the simple answer is yes. So there is a working group that is has been working around this, and there are a few additional areas of work that we are exploring in the sense of just understanding a further level of how people are currently working, equipment, space they need to work, etc. And then absolutely there will be principles and a policy to support.
And it's sort of connected, isn't it, as we were touching on yesterday, to a smaller number of places that will be.
Yes, absolutely. So it's true. They're all interrelated. Yeah.
Yeah.
I know when I spoke to staff during the roadshow, those staff who seemed most animated about their work and happiest with their work were the ones where they were able to say, oh, we've got a really good system in our team for the way in which we work together. And those that felt much more disenfranchised and much less happy about what they were doing didn't really have a story to tell about that. One young woman, two young women I sat opposite, I said they were obviously weren't very happy in their work. And I said, how often do you get together as the team? Yeah, we do it 1 day a month. And that's not enough. So I am very, very interested, as I've always been, in how we create order around the way in which people work, where they work and how they work, because I think it's key to what we want to go on and do. So for me, that underpins everything about Agile, really.
I'm just wondering about lessons learned from other large organisations on this, a bit like government, local authorities, because we've lived this and we've gone in and out of all sorts of
very mixed
issues, I'm just wondering if you're learning also from other large organisations with the work.
Yeah, absolutely. Picking up the learnings and overlaying that with what feels right for us, absolutely building on what Sue said, with the core principle being we want people to come together with purpose more often. So absolutely, but also I guess, and this links back to our values and behaviours, also not being afraid to try things, see what actually works and what doesn't work, and continue to iterate. Yeah, I think there's a big learning from perhaps organisations that have put in quite a fixed mandate around something that probably doesn't work, but something that is more iterative. It is helpful to explore how people can best work together.
Because I must admit, the place linkages we have with, say, healthcare committees, sat in a room face to face, is 10 times more productive and useful than Teams meetings and everybody working from home. I think.
Exactly.
To get that balance right.
I don't think you can ignore the skills bit in this either, because some roles lend themselves to always being in a workplace actually, and some roles could easily never step into a workplace, research roles, for example. So the coming together with purpose is really quite key. And the team charters and things that go alongside some of that is really quite key.
Being agile with it. Max, Brent, Peter?
Just really quickly then, some of this is also to having a common technology platform, sharing, collaborate. So we are in the middle of a procurement at the moment to bring our disparate IT provision for our corporate IT at the ICB under one contractual umbrella, which will be a real step forward from next fiscal, from March, April time. Should help us as well.
Lovely, thank you. Brent?
Yeah, I mean, we're all going through this, we're all having these conversations and trying to nail down really the right way or the wrong way of doing this. There's an emerging literature base, isn't there, that you could argue either way on these things. But just take us back to yesterday's conversation where we talked about belonging. Talked about competence and autonomy as being the key features of satisfied workforce and engaged workforce, and the belonging is the real starting point, isn't it? It's really difficult to belong to something if you don't go there, you're not with people. And then there was Bushra's comments earlier around the informal learning and the training and the opportunities to be around people, and you create obviously knowledge and competence, but also culture.
Peter?
I think that's really important, because you can do business through this, but relationships are built in 4 dimensions, aren't they? So holding on to that human connectivity, and I think the point that this is under we connect is very significant. The only thing I want to say is we just need to make sure that agile is held in the totality of what we're trying to achieve. So it is about, alignment strategy, so people are really clear about how their functionality connects. It is people centered, and then the technology, but also getting into our processes and structures. So it is the whole organisation, of which the policy is really important because it provides those guidelines. We just want to kind of hold it in that whole, because we will need to be an organisation which can flex and react far more quickly, fleet of foot, than perhaps traditional structures would be.
Yeah.
Great. Right, my last bit is I think most people are aware that we're going through organisational change inside the ICB, including the voluntary redundancy scheme that we're concluding over the next few months. And I just wanted people to be aware with a little bit more detail and evidence-based what workload that creates inside the HR team. I don't think you get this information very often. It's a small HR team, but you will be able to see from here that the amount of job evaluations, for example, that are being carried out just around 4 organisational changes. 100 job descriptions desktop, that was within like a 10-day period. Significant amounts of work go into that. But just the amount of emails, 800 emails requiring action. There's more emails than that, but 800 requiring action, again, in a 2 or 3 week period. I think it's helpful for people to be able to see that work is going on and helps that's continuous for us. It doesn't end till the people actually leave or the organisational change is concluded. And yet for most other people, of course, once the decision is made, that has ended, I suppose. So that's it.
Just in support of Jane, I think what you conclude from that, I think this is part of the broader work, is that there is a capacity question. So in terms of how we organise ourselves against this repositioning, we have to address the capacity questions for those things that we say we must be doing in the ICB. So because I don't think it's sustainable. If I can just make the point, because it comes up a lot, not just in this meeting. That's not a sustainable position, given the sort of framework that we've now designed. So our job in this next phase is about working out how to make sure that capacity is there, and that's what I meant about there being a continuing story here about how this, because this isn't actually somewhere up in the air. It's actually something that we're aiming to get to with a very clear plan for the next 18 months at least, and thinking beyond that. In order to implement in a coherent way April next year. So that it's really just to make that point, so it's clear from the board's point of view. There's going to be a continuing discussion about this.
Yeah, thank you.
Charlie, are you musing or about to say something?
I wanted to hang a couple of points onto Jane's item, but they're not directly related to what she said, but they're like market, if I'm allowed.
Sure.
The first is around widening access. Kind of connects to the opening discussion we had this morning about diversity and whether our workforce reflects the full diversity of the communities they serve, which might well help provide a better service to those. Anyway, widening access. With Pete, I've been discussing 2 sets of initiatives. Which are being supported by universities across the region. One is a network of community learning centres in our most deprived communities in Grimsby, Bridlington, Hull, and a part of York as well, where we are looking to open up opportunities for children in those areas, choices that they might otherwise not have through sets of after school and holiday activities. It would be wonderful to engage the NHS in its various guises in those community learning centres to provide examples, role models for those children to think into a different kind of future than that they have. And the other initiative is called Generation Research, which started in my university. It's now serving universities across the north of England. Which is focused on giving students taking STEM subjects, including medicine, work opportunities in lab-based contexts, which kids from better off backgrounds might be able to self-finance, but kids from worse off backgrounds can't. And the ambition is to bring the NHS in its various guises into that as a place which has labs which could provide work experience. So there's a wider question for me coming out of those things. And one of your subcommittees, Jane, has a theme, widening access. Widening access is not something you do at the point of entry to profession.
No.
It's something you have to do much, much earlier in the process. Do we think hard enough about that as an integrated care system? My second point, and it comes from a conversation I've had with the Hull York Medical School. Brilliant collaboration between two universities, commended for serving the needs of a rural coastal geography, under-doctored health service and health inequalities, with a strong record in widening participation in medicine. And we were talking about the NHS workforce plan, and the absence of a plan, the absence of a delivery plan for the NHS workforce plan. Such that we're getting 8 places more next year, and probably 8 the year, which is not going to scratch the surface of anyone's needs. So the question is, do we wait until from upon high somebody provides a slug of money, which they right now create another 50 or 60 places, which would be extremely difficult to do in a very short term, not least because of placement availability? Or could we, as the board and the system, work with healthcare professional training providers like the Hull York Medical School, Universities of Hull York and Coventry and Scarborough, to begin to think that through in a much more systematic way than I think is happening nationally? I know, Jane, some of that's happening through David, what's his name's group, but I think we need to connect to that national level and those national ambitions much more strategically than and I think we're able to do at the moment.
I agree, Charlie.
I was just going to connect back to the stuff we heard about midwifery yesterday. When I've forgotten Bill's second name. Thank you. When our expert told us that those who came through apprenticeships and were sort of hands-on from an early age tended to be really good and empathetic, and indeed you retain them for a long time. And those who came from presumably more privileged backgrounds and through elite education were a bit harder to hang on to, because the shock of the real world often led to retention problems. So I'm just connecting it to what Charlie's saying, really.
I think you've got to raise a question about the current status of the long-term workforce plan, actually. I'm building on what you've said, because the whole direction of travel that was in that long-term workforce plan is different to the direction of travel that we've got now unfolding around the community versus hospital scenario, particularly. I know there's work going on nationally looking at long-term workforce plan version 2, but that's unlikely to be before next summer, I don't think. So I think you're absolutely right that we've got to be in control of our own destiny in our own system.
Yes, Simon.
By way of example, I think I'm right to say it's the Royal College of GPs assessment of the long-term workforce plan is that it predicts or it aims for a 49% increase in hospital consultant work.
Exactly that.
And a 3% increase in general practitioner work.
That's exactly my point.
It's also not funded.
Yeah.
So that the education is potentially funded. You're kicking the can down the road about when the 10 years actually starts, but the employment of those people when they come off the training into the workforce plan isn't yet funded. So it is questionable as to whether it's worth the paper written on. But Charlie's got a very good point about certainly our local Hull York Medical School, which is not only does it have a very strong track record of recruiting locally, but also of training the right clinicians for the local demand and retaining them locally. And I say that as somebody, one of my youngest partner in my practice is a local chap who went to Hull York Medical School, trained on the York VTS scheme and came back to work with us.
Right. Lovely. Fabulous. And as we mature and we understand increasingly our role and how we begin to be able to draw together our various responsibilities, not least for the prosperity of the geographies in which we work. This is central to that, isn't it? The culture you want to grow as an organisation. What if everybody who worked in our organisations had some kind of role in the development of young people? You know, we should be offering work experience like nobody else at all sorts of levels. This should just be something that we do. And I think as we go on and develop, we need to take a lead on that, because it's just obvious, isn't it, that that's what we should be doing. Okay, any further comments for Jane? Thank you, Jane. So don't forget, this board offers its help to you in any way with those 3 leadership programmes. Item 14, this is you, Anya. This is working with people and communities. You're asking us to approve your strategy.
Yes, thank you, Chair. So very briefly, for long-standing board members, you may remember not long after we formed as an ICB, we brought first working with people and community strategy to the board for approval. I will just flag, it's not actually a statutory requirement to have the plan and approach itself, but it is usual to set out how an ICB intends to work with people and communities, and so therefore most, if not all, ICBs do produce a document not dissimilar to the one that you have in front of you. At the time, the approach was really building on the good practice that had emerged through the 6 CCGs, but of course over that time we have learned a lot more and have done a lot more work with our communities. And I would just like to, if I may, just for a few minutes, draw your attention to page 14, which identifies our key priorities, all of which are interrelated, and again comes from the learning that we've experienced over the last couple of years. So this sets out the priorities. So one, as you would expect to find, we really want to put that focus on strengthening the voice of underrepresented groups. And what I should have said right at the start is, of course, this is a vital pillar or foundation, whichever way you want to describe it, of our overall strategy of having voice at the heart. So this directly relates to that part of our overall system strategy. But as we know, we continue to struggle to make sure that the voices of our underrepresented groups are not just surfaced and listened to, but then actioned. And we had obviously part of the conversation about that earlier this morning. So that continues to be a priority for us. And in particular, we are working much more closely with our colleagues in the VCSE sector to really use existing networks and appropriate touch points to have those conversations with those communities, which leads to much greater insight. I will just also flag that our approach has evolved. So historically, our work was more concerned with the more statutory part of involvement. So talking to people about their experience of services, we want to change a service, etc. But what we have moved to and want to continue to move to, and it particularly relates to parts of our underserved communities, is understanding more about their behaviours and their thoughts and aspirations around health and well-being, because if we are going to make a shift, that part is really crucial. So I just wanted to flag that. The system working piece has really evolved and continues to be another priority. And 2 things to flag here. Some of you were party to a bit of a demo on this if you attended the staff roadshows. But we actually, after a workshop that was kicked off by our chair about 18 months ago, the full system has really come together, and a key output of that has been to develop an insight bank, which is a repository for all the rich qualitative insight that we have across the system. So that allows us to share that insight and also allows us to check what insight already exists before any one of us goes out and asks the same questions basically to the same community group. And we're working very closely with the business intelligence team to overlay the qualitative and quantitative insight. So we want to continue to develop that. And as we've touched on before, and I touched on on earlier, we are constantly looking for more innovative and appropriate ways to engage our population, and particularly digital and social media is already working in a much better way for us, and we want to continue down that route. The third one is around continuing to develop our diverse public and partner membership. So I've spoken about this at many of our sessions, particularly in the Voice of the Lived Experience part, but we've got now a very thriving, really, public and patient engagement network, which we've rebadged as Community Voices. So this is open to all PPGs, local authorities, interested parties, etc. I think we've got about 2,000 members of that group so far, which we want to continue to grow. If you work further through the document, there's the approach that we're taking, because we understand that different people, different parties want different levels of engagement. But this is primarily those groups and those individuals that are already engaged and want to be part of the system and want to be advocates, want to share their views and know more. The second part is around extending our Working Voices partnership, which is really successful in working with key employers across the region. It's primarily in Hull and East Riding at the moment, but again, we want to extend that. And again, it's a very successful initiative in terms of empowering employers to support the health and well-being of their staff, and also to allow us to share, again, relevant information with those networks. And then finally, we want to continue to develop that culture of participation, collaboration and improvement, and particularly, and this builds on a development session we had at board a few months ago, is that creating that culture that engagement and involvement is everyone's business in health and care. It's not just a particular team. So we've been doing a lot of work, and we'll continue to do work in providing relevant tools and training for our colleagues in the ICB and across the system to further enable and empower them to deliver better engagement and involvement across our communities. So those are just the things I wanted to highlight, Chair. Thank you. Colleagues are happy with the proposed approach.
I'm happy to approve it personally. Louise.
Yes, thanks, Anya. I think it looks really good. Just to say, in North Yorkshire last Monday we launched our involvement framework. So there's some real complementary work here that we can do together, and just make sure we're sharing between us. I've asked for a copy to be sent to you.
Yeah, we should go on in time. Look about how we do these things together, shouldn't we? Any further comments about the People and Communities Refresh strategy? Thank you, Anya. Item 15, I'm afraid this is you again, Anya. This is the EDS update.
Yeah, thank you, Chair. And again, this links obviously with the development session that we had this morning, but as a request by the board, when we brought the EDS outcome earlier in the year, there was a request for an update against the actions that formed part of that EDS submission. So I won't go through it all verbatim, but you can see there quite a detailed report that identifies the action that has been taken against each of those areas. As a reminder, in terms of EDS, that is the NHS framework for, in essence, reviewing our work in respect of EDI, and particularly looks through three key lenses. One being the services that are commissioned or provided by an organisation. So for us, it's primarily commissioned services. Staff health and wellbeing is the second thread, and the third thread is inclusive leadership. And you may remember that we had a rating of developing that was agreed, but it was certainly our organisational ambition, and certainly the board's ambition, to improve that. Just a reminder, there are four levels, if you like. Developing is the second level. It's then followed by achieving and excelling, and certainly our ambition over time would obviously be to reach excelling.
Can I just check? I just wanted to check if we when is the next assessment?
Well, it's supposed to be on an annual basis, but there's been a lot of feedback nationally to say that is because the process itself is quite onerous in terms of pulling together gather all the evidence. And so there's been a lot of feedback from organisations nationally to say it's not actually helpful to have it every year, because the focus then is more on the evidence gathering,
so that's
and the delivery of the actions.
In a sense, it's in our hands. I mean, it's like a bit, again, it's a thread through our conversation today and perhaps a bit yesterday, isn't it? Because what we started with this morning and what we've just been talking about with the leadership and talent elements, we address all of that and some of those significant things we heard this morning. And we need to satisfy ourselves that we're excelling, don't we? And then that would naturally sort of fall. So I mean, it just connects up, doesn't it? With
Absolutely, and you know, as is similar with any process like this, of course, you're only really reviewing the things that you're actually focused on and counting, and that's the point, really. So you can see against the specific actions that fell out of EDS, good progress is being made, and case in point around inclusive leadership, obviously the development session that we had this morning that forms the programme of that development session. So against the actions themselves, it's good. I think the wider piece, just to flag, and Jane and I from an executive level are picking this up, and it links again to the conversation this morning. It's the wider piece culturally around how we're truly embedding EDI, and it's the responsibility for EDI amongst all our workforce, and that's still something that we need to work on, because these particularly in terms of our commission services, obviously the three that we'd identified through the EDS have been reviewed and now have actions. We haven't necessarily done that for every other commission service, so that's something that we need to pick up, so we're not well, because it's the right thing to do, really. And the second one, and I think this was touched on earlier, and it was touched on in a presentation that we had from CAP a few months ago. Part of our biggest challenge, really, is that the data that we have available, because particularly from a lot of our services, if we don't capture the data around those patients, particularly through the lens of protected characteristics, inclusion, group, gender, etc., we're then not able to properly analyse where we might have disparities in outcomes, etc., and then can't put in the relevant interventions to then monitor the success of those interventions, if that makes sense. So that is still a big area across the system. That work is happening, but that is probably the area that inhibits us moving forward, really, in the way that we would ideally like to. So again, I hope that makes sense in the way that I've described it.
Thank you, Anya. Questions for Anya? Charlie?
Gender pay gap. Great that, well, we have to do it, don't we? My experience is that we've moved to publishing an ethnicity pay gap report. You don't have to, but it's really useful doing it, because you identify things you might not otherwise notice when you collect the data. And we're going to be moving ahead to do a disability pay gap. I don't know how far WRES and WDES are functional equivalents of that. But I recommend that we consider doing voluntarily, rather than because we're required to, pay gap reports for other protected characteristics.
Do you mean within our ICB, Charlie, or do you mean across the system?
The system. I mean, what Jonathan said earlier was ethnicity and gender is quite a shocking thing, really.
Yeah. Okay, we're in agreement. Thank you. Do you want to say something, Steve?
Well, only maybe the agreement, but I guess it probably just needs to be explored, and then maybe we, as an action, to follow through on and understand what how that will be taken forward. That's all I was going to say.
I'm just about to say the same thing.
That's fine. Yeah. Thank you. And now we're going to Jane. Jane, this is EPRR policy.
Yeah, thank you.
EPRR standing for
Emergency Preparedness and
Resilience and response. Resilience and response. Yeah.
It's a good job I've got a phone, a friend.
No, we're all the same.
Yeah, so the EPRR policy, so we had, it was initially written in 2022 as we became statutory body, and is expected to be approved on, updated and approved by the board on an annual basis. So basically the policy sets out will comply with the current legislation, and in terms of the policy changes that are in the document itself, mainly there's something about the team structure has changed as we've done a reconfiguration of the ICB. The team has changed. It does sit under Amanda and then under Sean. Before it used to be Julie, but now it sits there. So that's been a change in terms of line management. Also, there's changes to the terminology for the what we call JESIP doctrine, and it now references gold, silver, bronze have been removed and replaced with strategic, tactical, and operational. So that's the new terminology. References about personal development portfolios in line with the minimal standards, and we've all received emails about training that we all need to comply with. So there's an expectation of greater training for people. So the strategic, which is what the exec mostly do, and then the operational commanders.
Jane, is that ask that all board members do this?
No, it's the people that are on call. So we so not to strategic and operational. It just sits out in the policy with those people on call. But there's further training required, and we are expect to maintain things like portfolios, etc. So there's that bit that we need to do. There's an amended section on the governance to ensure consultation on emergency plans with partners. Just to say that this plan that sits underneath it, we have our role is about system. So there's an individual organisation, but it's mostly about system and how we manage the system. But we are, because we're a category 1 responder, we have got certain responsibilities that we need to do. CCGs weren't category 1 responders, so it is a lot more onerous, if you like, for us as an organisation than it used to be as a CCG. And then there's just there's a self-assessment that's due in September, October time, and we're just going through a process of that. Each organisation has to do it in compliance with the standards. So we're just going through that at the moment, and I've just had a copy in my inbox about our compliance and the self-assessment work that we're doing. And then we also have to have some oversight and assurance of the plans of providers that sit underneath us, and we'll have individual meetings with each one of the providers to do that. So it's that system real thing responsibility. That's
quite a piece of work, isn't it?
Yeah, it is. The team are very, very good, and to be perfectly honest, our resilience has been tested because we've actually had a few incidents. We had we've had the CARECOM issue recently in terms of primary care, and then there was the other, what was it called? CrowdStrike. That was also a test of our emergency resilience. The riots, although we didn't step into a system role, each individual organisation did their own, but we did have some learning, etc. from that. But we've had some good testing actually just recently. But I wasn't going to say anything. I don't know if anyone's got any questions.
So you've been asked to consider and approve the EPRR policy. Anybody who doesn't want to approve that? Great, it's approved, Jane.
Thank you.
Thank you. Thank you for the work. On to item 17, this is where we come back round, we loop back round to the board assurance framework. We think about what we've spoken about, and we think about whether we think we've got it right in our BAF. It does feel that we've been light on discussion about finance today. And probably a bit light on UEC, given our anxieties about that. But I think that there will in private be an opportunity to talk a bit more about both.
Yes, and I think I just come back to my point. I was looking ahead as opposed to what the reported position is. So I guess we'll come back to this as the next few months progress. But it was really recording my anxiety at the moment about some of those things. So,
Teresa,
obviously we've got the winter plan and later this afternoon, so we will pick up a lot more discussion around it then.
Thank you. And the exec are going to go away and give a little bit of thought about whether or not they think we've got a strategic risk that we aren't currently showing in our BAF based on our earlier development session. Anything else in relation to the BAF? Item 18, you have received the good news briefing as usual. I hope very much that you've read that. It is there to lighten the load, and I think probably astonish you with the amount of stuff that actually does go on inside the ICB. We had no questions from the public this month. There are no matters of any other business. My closing remark would be, I think this has been a very positive meeting, a very well-behaved meeting. Thank you all very much indeed.
Nobody dare do anything else, but anyway, when you started it.
Our next meeting is scheduled for Wednesday, the 13th of November. Do you want me to mention the thing that you mentioned to me?
Well, Jonathan's not here, but I think it's worthwhile. I think it's like a sensible suggestion, yes.
So on the 13th of November, Jonathan and his organisation, NLAG as was, are opening their CDC in Scunthorpe. And he's extending an invitation to this board to go and see the CDC and potentially hold our board meeting in Scunthorpe. I think that's probably a good idea. Don't know that we've done all the logistics understanding before we get there, but here's a heads up. So it's possible that we do.
He said he would provide all of those for and in the existing boardroom. So yeah.
Okay. So maybe we get to go and have a look at the CDC, which I think would be great because we've talked a lot about CDCs, haven't we? And we know we're hanging quite a lot on their success. That draws our meeting to a close. Thank you all very much indeed. Thank you to those who've watched us on the live stream. It's 1:20. We were due to get back together at 2 o'clock. Would you like me just to nudge that on to 10 to 2 so we buy ourselves a little bit more time? Yeah. Okay, so let's resume at 10 to 2 then with the meeting of the board that's held in private. Thank you.
Oh, well, that, go on. Go on.